All right, good evening. It is February 2nd, 2021, and welcome. My name is Greg Martineau, and I am the superintendent for the public schools of Northborough and Southborough. And I want to welcome our attendees, our families who are joining this webinar this evening. And I just want to quickly go over the agenda and kind of set the stage for this webinar. So we'll do welcome and introductions with our panelists, and then we'll talk about what we hope to accomplish in the next hour and a half. Then we'll hear a presentation from our medical advisory team, and then talk about logistics of increasing in-person learning. And then we will answer specific questions that were submitted via the form from families. And then lastly, we'll end by talking about next steps and what to expect in the future. So I'm going to skip order of the agenda and begin by talking about what we hope to accomplish in this webinar. So first, I just want to take a minute and thank families and educators and students for the tremendous journey that everyone has been on in terms of trying to accomplish this academic year. I hope we never have to repeat this type of year again, in my career at least. And I just want to acknowledge how accommodating educators and families have been with students at the center of this work. So again, thank you. And I know has not been easy. So as we launch this school year, we always put in-person learning at the greatest priority in terms of the most effective type of learning. Looking at the health and safety of our students, faculty, and staff was a high priority. And we launched the school year in a hybrid model with the knowledge and the evidence that we had at the time. Increased in-person learning was always the goal of the district. We put forth the hybrid model because we thought that was the best model at the time. And throughout this year, we've made evidence-based decisions, working in collaboration with our medical advisory team, making sure, again, the priorities were health and safety of our students, and making sure students had academic experiences that were helping them grow socially, emotionally, and academically. The webinar this evening is really about looking forward and planning forward. We have plans in place to increase in-person learning in the near future if conditions allow. I just want to share that planning is what we do well, and there are a lot of different factors in order for us to increase in-person learning, from working with families, working with educators, looking at schedules, looking at furniture, looking at our operations. So it is a complex endeavor, and we need to plan forward so we're prepared for when we're able to increase in-person learning. So those are the goals for this webinar this evening. And at this time, I'm going to stop sharing my screen, and I'm going to turn it over to Mary Ellen Duggan to start introductions of the district leadership team. And then after the district leadership team, we'll introduce our medical advisory team. So Mary Ellen Duggan.
Hi everyone, I'm Mary Ellen Duggan. I'm the District Health and Wellness Coordinator and Nurse Leader. I'll send it over to Rhoda.
Good evening, I'm Rhoda Webb, Director of English Learners and Equity. Stephanie.
Good evening, my name is Stephanie Reinhorn. I'm the Assistant Superintendent of Teaching and Learning. Oh, I'll send it to Keith.
Good evening. My name is Keith Lavoie. I'm the Director of Operations for the school district, and I'll tag Marie.
Hi, I'm Marie Allen, Director of Student Support Services, and I don't know who to tag now.
I think that's it, Marie. And now I'd like to introduce our amazing medical advisory team. There is one person that's not here tonight, and that's Kristen Black, and she is the Northborough Board of Health agent. And she is busy setting up a vaccine clinic for the first time today. So that's where she has been today. And I will send it to our Southborough Board of Health. And we have our newest member of our medical advisory team, and that's Heather.
Heather Alker, yep, at UMass Memorial Department of Family Medicine, and I've just taken on the Public Health Director in Southborough role. And excited to join this great team.
Then we'll do Emily. We'll keep it in Southborough.
Hi, I'm Emily Amico. I'm the public health nurse in Southborough. Thanks for having me tonight.
And then we have our school physician.
Muted. Hi, I'm Safdar Medina. I'm a pediatrician at UMass Memorial and our district physician.
And then the three other physicians on our medical advisory team, Dr. Costigan.
Hi, I'm Amy Costigan. I'm an emergency physician at UMass, and I'm the director of the emergency department at Marlborough Hospital and a parent of 2 kids in Southborough.
And Dr. Carey.
Hello, I'm Jennifer Carey. I am an emergency physician and medical toxicologist at UMass and a parent of 2 kids in Northborough.
And Dr. Ciarinello.
Hi, I'm Andrea Ciarinello. I'm an infectious disease physician at Mass General in Boston and the parent of 2 Southborough students and 1 Algonquin student.
Okay, and then I'm going to hand it over to Keith to introduce Kailash.
Yes, I'd like to introduce Kailash Viswanathan, who has been our engineer consultant from the very beginning. Welcome, Kailash.
Thanks, Keith. Kailash Viswanathan, parent of 2 kids, 1 in Lincoln and 1 in Algonquin. Thank you very much.
And before we turn it over to the medical advisory team for a presentation, I just want to also acknowledge the expertise and guidance that the medical advisory team and Kailash has provided the district. We have met weekly and they've been a tremendous resource in terms of bringing expertise and current research and helping us make evidence-based decisions around the path forward. So I just want to thank everyone on the medical advisory team in advance. So thank you.
All right, perfect. Do I have ability to share my screen, Mr. Martineau?
You do, yes.
Perfect. Right, and Dr. Medina is going to start us off.
Thank you. So the first slide that I want to talk about is CDC data. And as the CDC has been tracking all cases since the pandemic started, and as of January 2021, we've seen 2.9 million cases reported between the ages of 0 and 24, which account for 12.6% of all cases recorded in the United States. That age breakdown, if you look at it in more detail, shows that 57%, or the majority of them, were actually ages 18 to 24. And the breakdown between school age was 5 to 10, about 11%, 11 to 13, 8%, and 14 to 17, 16%. And you notice some variability in there. 5 to 11 seem to have somewhat of a higher rate, and that is because younger children have difficulty in isolating from household contacts, and the primary mode that they acquire COVID-19 is through household contacts. 11 to 13-year-olds can isolate in the home if there's a household contact, but they're also more likely to possibly have some outside interaction. And 14 to 17, while they can obviously isolate from their parents, are more likely to have social interactions outside of school. Looking at the data in more detail, the rises that occurred in the rates in ages 0 to 17 over the past few months paralleled the community rates, and the age group of 18 to 24, however, the rates were greater than the rates at which the rest of the community increased. As of December 6th, the last collaborative of this data, counties in in-person learning and counties with remote learning had equal rates among their K through 12 students. And this one is Mary Ellen.
This one is just a graph of the cases in Northborough are in blue, and the cases in the town of Northborough and the town of Southborough are in red. The green line is the cases, the total number of cases in our school district, and the yellow line is the K to 5 cases that we've had throughout the year in our school district. And this just backs up what Dr. Medina said, is that the school cases tend to mirror what the town numbers are doing.
So what we want to do is look at health outcomes for children as a more global picture. And we know that children can become infected with COVID-19. We know that they're less likely to become severely ill than adults. However, what is uncertain right now is to what degree forward transmission from children occurs. A lot of data does state that children under the age of 10 are less likely to transmit than children over the age of 10. We're balancing all this with the adverse child health outcomes that we're seeing, such as obesity, undernutrition, mental health, and substance use, the likelihood increased physical or emotional abuse at home, and a hindrance to their academic and social emotional development. One of the complications that we hear about, particularly in young elementary age children, is multi-inflammatory syndrome in children, or MISC. This is a condition that causes generalized inflammation in the body that can affect different organs, that typically occurs after a COVID-19 infection or positive test. Typically, it is 3 to 4 weeks after that diagnosis. Most of the cases are between the ages of 1 to 14, with an average age of 8 years. As of January 8th, 2021, the CDC reported that there were a total of 1,659 cases nationally of MISC, accounting for roughly 0.1% of all cases of COVID-19 between the ages of 0 and 17, and 26 deaths. In Massachusetts, right now, 51 plus cases have been reported. It's worth noting that admissions to Massachusetts Children's Hospitals did peak for MISC during the post-holiday surge. And this graph shows a daily 7-day moving average of MISC cases. And as you can see, the highest that this moving average was just above 15 cases per day, which was in May after the surge in the Northeast, because this is national data, a second wave in the summer after the surge in the Midwest. There's a gradual decline there, and as I mentioned, if this continued, there'd likely be a post-holiday surge, but regardless, the numbers of the 7-day moving average of MISC cases are very low. So what has gone on nationally with schools? And I think it's important for us now to look at some of this national data and learn from it. The first study I'm going to talk about is a study from Mississippi that was done by the CDC that compared children who tested negative for the virus that causes COVID-19 versus children who tested positive. And as you can see, children who tested positive were more likely to have attended gatherings and not more likely to have attended school in person. This was a case control study of 397 children and adolescents who presented to medical care facilities, comparing the positive cases versus the negative cases that were the controls. Testing positive was not associated with being in school or childcare 14 days prior. And among the 236 children in this study that were in school or childcare, masking by all students and staff reduced the risk of testing positive by 60%. Testing positive was associated with close contact with someone with COVID-19, more likely a household contact, attending a social function, attending activities with children outside of school where mitigation protocols were not followed, or having visitors in the home. Looking at that in even more detail, schools in Mississippi reopened in the fall, full in person using 3 feet of distance. In the study, close contacts of positive cases were more likely to be family members than classmates, and in-school attendance did not correlate with an increased likelihood of a positive result. In-school cases that did exist were associated with inconsistent mask use, and one of the conclusions of the study was that mitigation in school is effective. A study out of Wisconsin came out just last week and did 3 months of data collection in 17 Wisconsin K-12 schools. They used cloth masks. The children were all 6 feet from adults in cohorts of 11 to 20. They did not report the completeness of their contact tracing, but as you can see, the school incidence among the 191 cases reported was lower than the county incidence by 37%. The breakdown was 133 students and 58 staff. There were 7 likely in-school transmissions. All were students, 5 elementary and 2 secondary school students, no staff cases at school. And Wisconsin schools were sort of all over the board. Some were hybrid, some full in person, and some did go down to 3 feet of distance. Really good data came out of Lincoln, Nebraska. This was done by their local board of health, and they followed staff coronavirus rates between September and December, and they compared them to community spread. Background on that is that elementary schools and middle schools in Lincoln, Nebraska were full in person down to 3 feet of distancing as needed. The high school was hybrid, but they have plans to move forward with full in-person learning. Educators and families were very comfortable with this plan and mitigation strategies. I was able to interview a Lincoln, Nebraska teacher on her impressions as well, and that's what she had said. So what does this show? That staff from middle and high schools had a lower positivity rate than the community throughout the period. They then noticed that during the month of November, staff from elementary schools had a slightly higher positivity rate than the community, and that led them to investigating this further. The first thing that they noted was that classroom teachers had a similar rate to office and administrative staff, which indicated that this transmission was likely not occurring in the classroom setting. They found some student-to-staff transmission, but this was due to mask exemption in students with special needs. And of note, the staff did not have eye protection or a surgical mask, which would help when obviously a staff member is one-on-one. Most transmission they found was staff to staff and associated with unmasking and in break rooms. An interesting finding also with the substitute teachers who were around different children all the time had a significantly lower rate than other teachers in the districts. The Chicago Archdiocese also published their data. They have 91 schools. They have been full in person since August. The only time they're 6 feet apart is at lunch when they're unmasked, and it's less otherwise as needed. It's the largest private school system in the country. And throughout the time period that they collected the data, student and staff in the schools had a lower rate than the community overall. They identified 3 clusters over a 2-month period. 2 involved only staff. 1 involved a student and a staff member. 2 of the 3 clusters were associated with non-adherence to physical distancing outside of class time. And there was 1 cluster in which transmission in the classroom setting could not be ruled out. This was just made available last week, and this is data from 2 independent school districts that were called A and B in the study. One was in the Mid-Atlantic and one in the Southeast. Both districts had full in-person learning with multiple mitigation strategies in place: cleaning, masks, distancing, and very importantly, screening, as our district is embarking on. District B spaced 5 feet due to space issues. District A was able to use 6 feet and bring back their kids in every day. The majority of cases they identified, both in their screening and students who had positive tests outside of their screening, did not lead to in-school transmission. 91% did not. And 54% in school A and 85% school B were identified through their screening program. Of the 45 introduced cases, 5 secondary infections in District A, and of the 24 introduced cases, only 1 secondary infection in B. The in-school transmissions occurred when mitigation protocols were not followed, either inside or outside of school. In District A, one of the clusters was actually linked to a high school party with dozens of students. Both of these schools were able to maintain full in-person learning despite increasing community rates, and in-school rates were always lower than community rates. I was able to gather some data from a local parochial school. This school has been full in-person, all grades, pre-K through 12 since August. They've had high school athletics using MIAA guidelines. They have had 3 feet of distance, including in their high school students. Masks were required for all 2nd grade and above, which is the minimum DESE requirement. Our district requires masks for all grades. The rates increased as community rates did, which is a theme you've heard. And after some initial anxiety and bumps in the road, positive feedback from parents and educators on the model. They reported 2 cases of possible in-school transmission. One was in their after-school program and a possible staff-to-staff transmission linked to meal sharing. And one was in one of their younger elementary grades where no masks were worn. And it was 1 student who transmitted to only 1 other student in the classroom. All the other students in that classroom and the teacher tested negative. I also pulled some of my own clinical experience data. In COVID testing from December 15th to January 31st, what I typically do is test every symptomatic child, and the rate of testing approximately was about 14 tests per week of all symptomatic kids. During this time period, I had 18 positive COVID-19 cases. All had mild illness. 13 of them were from a known household contact, and we knew about the household contact before the test. It was a parent or another adult, and some in this group were siblings with the same common household contact. 3 were linked to an indoor social gathering where masks were not worn. 1 was linked to a gym where protocols may have not been followed, and 1 was in a club sport that may have occurred in activity outside of playing that sport. And I'm going to turn it over to Mary Ellen.
This is our district data from the beginning of the year. As weekly, as you can see, the numbers that are the red little blocks on the graph are the K to 5 positive cases, and the blue are 6 to 12 cases. This data is available on our district dashboard every week. It's updated on Sunday evenings. What we want to know is we've had 197 positive cases from the beginning of the year. 151 of those were students and 46 were staff. Of those 151 students, they came from 111 unique addresses. So what that means, I think this is important data to have, because sometimes you'll receive a letter from Mr. Martineau that says there were 3 cases in a school. What we can't tell you is that maybe those were siblings, or maybe they were relatives that lived in the same household. So that's good data to have in mind, that they came from 111 unique addresses. And that ties in with everything that Dr. Medina has said about household contacts and the spread in households that we've seen an increase of lately. In our pre-K to 5 population, the positive cases, we've had 80 positive cases since the beginning of the year. 55 of those are students from 44 unique addresses, and 25 were staff. In our district, when there are considered close contacts of someone that's been within 6 feet of a positive person or a household contact, they're quarantined. From the beginning of the year, in the whole district, students who have been quarantined due to close contact from household close contact or outside of school, there's been 520 students. And from those 520 students that were quarantined, 152 of them tested positive. So that's about 1 in 3. The quarantine that we have for close contacts at school, we've had 350 students who have quarantined. We have to remember that in our elementary schools, we quarantine the whole classroom due to the amount of cumulative time they spend together, even though 6 feet of distancing is maintained at all times as possible. And from those 350 students that we quarantined, there were 5 positive cases. So that's 1 in 70. When we go down to the elementary school, the ratios remain about the same: 222 household contacts with 55 positives, and 284 in-school close contacts with 4 positives. Dr. Cirinello will get more into depth about the positive in-school contacts on a later slide.
So one of the big questions is why, why move forward? And one thing we all know is that school is vital. School connections are important for our children. We know that positive connections in school are associated with increased self-esteem, lower rates of anxiety, depression, and high-risk behavior. For many vulnerable children, school is their safe place. And we know that school is most often the place where mental health concerns are first noticed. And school is vital for kids for nutrition and physical activity. So what we have seen over the past year is an emerging health crisis in our children, and even in the youngest of children, we're seeing rising rates of depression, anxiety, and suicidal ideation. We're seeing an alarming rise in childhood obesity and an alarming rise in children with ADHD that are struggling with school. I pulled some clinic data on these types of visits, and I had 670 patient visits, all my patient visits from October 15th to January 31st. Saw 76 visits for new or worsening symptoms of ADHD, 53 for depression without suicidal ideation, either a new diagnosis of depression or worsening symptoms, 43 visits aside from those 53 with expression of suicidal ideation, and 18 visits with new onset or worsening anxiety. A large-scale study out of China with students from grades 4 through 8 saw increases in symptoms of depression, non-suicidal self-harm, suicidal ideation, suicide plans, as well as suicide attempts. And our national data, compared with 2019, the proportion of mental health related emergency department visits for children ages 5 through 11 increased 24%, and 12 to 17 increased 31% in 2020. And we have a lack of available child psychiatry inpatient beds, which has meant waits up to 7 days in the emergency department. And Dr. Costigan is just going to talk a little bit about what she has seen in Marlborough Hospital before we move on to the next slide.
Yeah, I would say, you know, I 100% agree with this. We're seeing really dramatic increases in mental health patients in the emergency department, and in particular pediatric patients who are struggling with, you know, anxiety, depression, suicidal ideation, high risk behavior, really due to lack of support and structure that they normally would get from school, as well as peer interactions. And if you ask me or any other ED director across the state what keeps us up at night right now, you're going to get the exact same answer every single time. It's COVID, which is obvious, and it's the pediatric mental health patients. The volume of them and the amount of time that they're spending in the emergency department. Up to 7 days, actually, I would say is a very low underestimate. We have kids who are waiting weeks in our emergency department. If you can imagine a 12-year-old sort of living in the emergency department for 3 weeks, waiting for a psychiatric inpatient bed. And we talk a lot about access to care for COVID patients, but really, I think you kind of have two pandemics going on. One that we talk about a lot, and this other one that is, you know, in some ways equally as important, that doesn't get talked about as much. So these are really big concerns that we have to think about when we think about the safety and well-being of our children.
Thank you. The Las Vegas School District was recently in the news. They reported 18 suicides over 9 months of remote learning in their children. This was double the 9 the district had the entire previous year. 6 students died by suicide between March and June, and 12 additional ones died by suicide between July and December. The student who wrote a note saying he had nothing to look forward to. The youngest student lost to suicide in that district was 9 years old. Obesity. So collectively, pediatricians are reporting the same clinical experience of rising BMI values, with children gaining as much as 20 to 30 pounds in a year. The American Academy of Pediatrics sounded the alarm last month about this. All these children have a risk of long-term complications such as type 2 diabetes, fatty liver disease, or hypercholesterolemia. And it is all due primarily to less physical activity, more screen time and snacking, eating out of boredom, and inconsistent sleep schedules. AAP sent out a warning, the American Academy of Pediatrics, just recently about rising rates of myopia or nearsightedness in young children, primarily due to decreased outdoor time and increased screen time. We know that young children's eyes are more sensitive to environmental factors, and we know that young children are in a critical stage for risk of development of myopia. A large-scale study out of China with 125,000 children ages 6 to 13 evaluated their school-based vision screens, and data from 2020 showed increased prevalence in the age group 6 to 8. The 2020 prevalence was higher than the year with the highest prevalence of myopia during the period of 2015 to 2019. And as you can see, some of the numbers are quite significant. Ages 6, 21% had myopia in 2020 versus 6% in the highest incidence between 2015 and 2019. The difference gets less as they get older, and they found no differences between no difference in the older kids, ages 9 to 13. And ADHD, the American Academy of Pediatrics had said this repeatedly, the students learn best in person, and schools should obviously reopen if they can do safely in their communities. A study out of Ohio interviewed parents of children with ADHD, and they reported more learning difficulties than obviously children without ADHD, and it was a pretty significant difference, 49% to 4%. And we know children with ADHD struggle with executive functioning skills. They have trouble organizing which tasks to start first. They have trouble managing their time, finishing tasks, and keeping track of tools for the task. Students with ADHD need structure to their day to be able to function at their best. Different schedules and routines, whether it's at home or at school, can increase the child's ADHD symptoms. And this has set an alarm in the pediatric community because it has meant starting more medication or increasing medication with risk of side effects. And parents, because their children struggle so much, have reported joining learning pods, and sometimes with different towns, or hiring in-home tutors, which ends up posing more risk, is because in these familiar settings, we're more likely to let our guard down with regards to masking. And I'm going to turn it back over to Mary Ellen.
Oh, you're on mute, Mary Ellen.
Thanks. So this is just a little synopsis of the data in our town that we've had so far. In our 10 schools, we have about 800 educators and staff and about 4,100 students. Since the beginning of the year, we've had 197 total cases. K-5, as I said earlier, has had 80 total cases. With the 350 in-school contacts, all were quarantined and most were tested. A lot of you know that recently Department of Public Health has changed their quarantine guidelines and had the options for shortened quarantine if criteria were met. And since we've seen that shortened quarantine, more of our close contacts are being tested. From January 1st to February 1st, of the students who were considered identified as close contacts in school, 91% of them were tested on or after day 5. All of those who tested were negative, and the 9% who chose not to test opted for the 10-day quarantine option. Of all of those that have been quarantined since the beginning of the year, the 350, there were 5 positive individuals. And of those 5 possible or probable in-school transmissions, when we do have an episode of an in-school transmission, we really dive deep into what happened, how it happened, and if there was any breakdown in any of the mitigation strategies that we've had. So some of the episodes we've had, it was in a PE class where they were doing stations and the students were less than 6 feet while exercising, and they had frequent water breaks and mask breaks, although those were 6 feet apart. In an elementary school where a student was not feeling well, just out of sorts for the day, and the teacher was helping them out throughout the day, and they were having a hard time keeping their mask. The student was having a hard time keeping their mask on. Individuals who attend work or school while they were symptomatic. What we're noticing now, even mild symptoms, we need to be really aware of even mild symptoms or mild changes in our bodies and take those all seriously. A lot of people think it's just allergies or just a stuffy nose, and it really warrants testing and follow through on that. And then where people had shared a space without masks, they were closer than 6 feet. None of our possible or probable in-school transmissions to date have been associated with lunch. So I know when we say possible or probable, because we can never be 100% sure where we get the virus from. We can look at all the data and wonder, but there are also outside factors that might play into it. So that's why we say probable or possible or potential. We don't commit to it being 100% in-school transmission because we can never be 100% sure where the virus came from when we get it. Oops. That's it for me. And then Andrea?
Sure. And let's see, Marielle, can you just go back one slide as well? Sorry. Yeah, I just wanted to say too, I think this is where I think we as the medical advisory team have really taken responsibility for this and tried to make sure that every time there was a possible in-school transmission that we really thought hard about, was this something that could be explained? And if it could be explained, what could we do to support people to help make adherence to these recommended mitigation strategies easier? So I think a lot about sort of like structural support for people. Like if someone came to school symptomatic, what could we do to make it easier for them to get tested? What could we do to make sure that they realize that, if it were, for example, someone were coming to work symptomatic, what could we do to make sure they realize they're not burdening their colleagues by calling out sick? And so I think the district has done a really outstanding job of really looking into each of these. I work with a number of different districts, and I think in many cases, as Mary Ellen said, sometimes you can't tell. And so sometimes where people got COVID. And so sometimes people will say, oh, it probably wasn't in school. And I think we've been really conservative about trying to assess whether it might have been in school and what we could just reinforce about how to prevent something like that in the future. So these are 5 more cases of possible in-school transmission than I would like to see, but I do think in every situation there's been an opportunity to really focus and reinforce what we can do to prevent that kind of thing in the future. So now we can go to the next slide. So I think all of the folks on the medical advisory team have been working really hard to try to figure out what data do we have, and a lot of the data are not totally perfect. Like they're definitely not as robust or as national in scope as we would like them to be, but we have a team of doctors from across the state who have been trying to keep track of all of the data that have been coming out really internationally and nationally since about June. And Dr. Medina presented a lot of those data. I'm going to have a visitor in a second, I think. Dr. Medina presented a lot of those data, and I'm just going to highlight a couple other data sources that I think are useful. Some of the questions came up in the chat about sort of, how similar is our district to the other districts that we have detailed data on. So some of these are a little bit more national in scope. And so I think in terms of the national side of things, I'm hopeful that with new CDC and HHS leadership, we'll start to have some national data and some slightly more comparable data collection across the country. For now, we have the 2 studies that were shared from Mississippi and Wisconsin. In the absence of that sort of federal data collection, the American Superintendents Association and some investigators at Brown put together a dashboard. The link for it is down here, schooldashboard.com. And you can go and kind of look at, these are voluntary reported school associated cases. So they don't dig at all into the question of whether there was in-school transmission, but just districts voluntarily report cases among students and cases among staff. And then this group is trying to sort of show the results for those rates stratified by type of learning model, hybrid versus remote versus full-time, some information about distancing and masking. They do have information on the grade level of schools, and then a really nice comparison to community incidence rates. So you can see whether students or staff are at higher rates than in the community surrounding the school district. But that's all voluntary data, so subject to the same limitations. I don't know whether people might over-report or under-report their cases. And so to try to get around that, several places, the largest of which is probably New York City, are starting to do asymptomatic screening. We'll talk more about our asymptomatic screening program a little bit later, but they're taking a random sample of students and staff across the city who are in-person school and screening people who are asymptomatic. And so these data are maybe a week or 2 old, but as of that time, they had screened about 209,000 staff and about 151,000 students and had about 1,900 positive people. So that rate translates to 0.52% of all cases, of all people tested, and 0.45% of the staff and 0.61% of the students. The New York City data got a lot of interesting discussion because people compared it to the community positivity rates and pointed out rightly that people in New York who are seeking COVID testing have a higher rate of having COVID because it includes people who are symptomatic or people who are contacts. But I actually think if our question is, I think a really important concern is how much COVID is in our schools that we just don't know about. And in that case, the testing of asymptomatic people really is the way to try to get at that information. And then we're doing a lot of work with local districts. Mary Ellen shared some of those data, as did Safdar. I think it's really important to support data sharing from districts. And I think our district has actually been very generous in sharing the data that you've seen here with other districts as well, and trying to help others understand where things have gone well and where there could be opportunity to make improvements. Next slide, Mary Ellen. So these are the data that the link got cut off there. Apologies. I think it's on the previous slide as well. These are the data that the Massachusetts Department of Elementary and Secondary Education collects from districts and reports weekly on their website. And so they show you the number of cases in students and the number of cases in staff. And the criterion is people need to have been present in the school building in the 7 days prior to their diagnosis of COVID. So people who are fully in remote learning are not included in this reporting. And you can see that the rates kind of track week by week after the holidays, as we've seen on all the other data reports. these estimates translate to about, it didn't come through on the slide here, it's about 0.5%. Let me just check and make sure I've got it. It was 0.5% of staff and 0.1% of students, or vice versa, but I want to make sure I tell you the right thing. So I'll come back to that. And as we mentioned, these are really, there's no effort to determine whether there was in-school transmission. This is just people who've walked in the door and have COVID. What we don't know that I think are really important is how does this compare to rates in people who are engaged in remote learning? And the data publicly are not stratified by elementary versus secondary schools or by model of schooling. So hybrid versus full-time in person. Next slide, please. This is a checklist that's been developed by some groups of districts around the state to try to make recommendations. It was primarily geared for districts who are considering opening and haven't really been able to bring many of their students back in person yet. But I think it's helpful just to review that these are the elements that we also thought were really important to have in place. And so we've talked about masks, distancing, ventilation, cleaning, hand washing. We've talked about the importance. Well, I think it's important to have a medical and public health advisory team, and that people can hopefully bring their questions to. Having clear protocols for students and staff with symptoms so that it's very easy and obvious for people to know what to do in terms of seeking testing, when to isolate, that there's a dedicated effort made to identify contacts and that those contacts will then quarantine and seek testing. We talked about sort of structural supports, but particularly support for staying home when people are sick or when they're exposed. And these include things like sick leave policies and backup childcare plans, staffing plans. The educators on the call can speak more about this, but the ability of sort of in-building substitutes so that there's always a pool of people who are able to support an educator if they need to call out sick. And having spaces for eating and drinking where people can be distanced from each other and there's adequate ventilation. We'll talk a little bit more about transmission in break rooms for adults in the workplace has really been the predominant mode of transmission that's been seen across a number of different workplaces, and that's true for the data that we have for schools as well. And then a transparent process for sharing outcomes, so like the district dashboard that we have that shows the cases that we've seen across the district over the semester. So we're going to talk a little bit about masks. I thought this was a nice review from the journal Cell, which pulled together a summary of all of the epidemiologic data in support of mask wearing. I think most people are familiar with the effectiveness of masks, but I think just to point out, these are really great examples. A couple that I really thought were anecdotally very powerful. There's a CDC study of hairstylists in Missouri where 2 hairstylists came to work with COVID and they were symptomatic. So sort of what we said, we are trying to support people not to do, but they came to work while sick. They were masked and they had collectively 139 clients who were also masked and nobody got COVID. So they're close in people, near people's heads for some prolonged period of time with no transmission. And then the one that, it sort of speaks to my own experience is a nice study out of Boston, 2 large Boston hospitals, where as soon as we instituted universal masking of employees, the rate of transmission among employees went way down. And we still are not seeing people transmit to each other in the hospital where everybody is wearing surgical masks and people are actually quite close to each other, sharing workspaces that are several inches apart and haven't seen transmission. Next slide, please. So a couple more slides on types of masks. I think double masking is getting some interest lately. So there were a couple of studies that came out in the last few weeks that I thought were really helpful. So this was a study in that same Cell paper that tried to review data on the efficacy of different masks and different mask combinations. So they compare all the masks to an N95 mask, which is the mask with the highest filtration effectiveness. And certainly if people have access to N95s and have been fit tested for N95s, that's probably the most effective mask to wear to protect yourself. I think they're really uncomfortable to wear for a long period of time. And the supply still remains somewhat limited. So most people are trying to reserve them for hospital settings. And the big kicker, I think, is that you have to be fit tested for them to make sure they fit you appropriately. Otherwise, they're not this effective. And so in this study, what they found were the most effective types of masks for use in the community are shown here. So they recommend either a 2-layer mask with a very tightly woven fabric or a surgical mask. And if you wanted to increase the effectiveness, you could wear a surgical mask underneath the cloth mask or you could wear a cloth mask that had 2 layers with a filter in between. And then on the next slide is a newer study that I thought was actually even more helpful. So they studied what they called fitted filtration efficiencies. So they put a little sensor under the mask, and then they sort of, spray particles at the mask and see what concentration of the particles get onto the inside of the mask. And I sort of lament the fact that they used an adult male model, because we have a lot of data from other studies that talk about, generally speaking, the fit of masks is less good for women and less good for children. And so I wish they had used some more representative models. But here's this gentleman. And so the most effective type of sort of cloth mask is shown on the top left. And this is a 2-layer nylon mask, and that blocked 79% of the particles from getting through to his face. And you can see that some of the other cloth masks were much less efficient, with a they call this a 3-layer cotton mask, was the least effective at 27%. And again, they compared everything to the N95, which was 95%. The gaiter also didn't do very well at 28%, so I thought that was interesting too. And then we always talk about surgical masks as being, sort of the second best to N95s, but I thought this study really highlighted how the fit of the mask is very important in its effectiveness. So just without any modification, the surgical mask had a filtration efficiency of 39%. But if they made some small modifications to it, like tying the ear loops and then putting it on, or using one of these sort of these 3D printed mask holders that sort of spare your ears as well. Although his went over the ear, so I guess you can't just put it down at the nape of your neck. Or this is like a little butterfly hair clip. And then these 2 contraptions worked very well, but strike me as very uncomfortable. So this is made out of some sort of rubber band contraption. And then this is a piece of pantyhose over the surgical mask. So, there are lots of options. I think that I thought this was valuable in terms of giving people an idea of what you can take control over in terms of increasing the effectiveness of your mask.
Can I just throw one more thing in there?
Yeah.
So in addition to having a well-fitting mask for your child, thinking about how often you're using it. So if you have a cloth mask and you're laundering it every day or every other day, eventually the material will break down. So there's no specific guideline on how long you can use a reusable mask, but some people have kind of suggested if you hold your mask up to a light, and if you can see a lot of light coming through, that might be time to throw that mask out and get a new one.
Totally agree. Thank you. Okay, so we can go on to the next slide. Let's see. So this slide is just highlighting the importance of some of the protocols that Mary Ellen mentioned in terms of having, making sure that people know what symptoms are concerning. We've seen just so many patients over the last, many months who really thought they had allergies or just had a little cold, or especially in young children, I think just sort of like nasal pain. So it really can be very non-specific symptoms. So I think if your kids have any of these symptoms, we've worked pretty hard to try to make it as easy as possible to get tested. I know it's a pain in the neck and it's not as easy as I'd like it to be, but Dr. Medina and Mary Ellen have come up with places around that have the easiest access to testing and hopefully the quickest turnaround times. And then, we've been conservative in the definition of close contacts in the classroom. As Mary Ellen mentioned, a lot of districts are really only using the 6 foot for 15-minute criterion. And then we have tried to be more cautious, and at the elementary level have considered the whole class a contact. And then we talked about the different ways for determining the optimal sort of quarantine and testing plan. And this has really been the dedication and work of the school nurses who've been in touch with everyone and done all the contact tracing along with the Board of Health from both towns, and help people outline their sort of 3 quarantine options now from CDC or from the DPH that people can follow. Let's go to the next one. Great. So maybe I'll just say quickly, there are a couple of questions in the chat about the data that have been presented, and how representative are these of all districts. I will say they're not as they're not as complete as we'd like. I think it would be great if every district in the country could report the same kind of outcomes and could give us the same information about what they're doing in their schools for mitigation. Like, are they at 3 feet or 6 feet? What did they do for their ventilation? We've been trying to do a lot of work with DESE and the Department of Public Health to try to get some of those data from Massachusetts schools. So I'm hopeful that we may have more data there, but really What we're showing you is the best we've been able to find, sort of combing through the literature. And I think Dr. Medina's read every single paper and looked for the word distance in it since it's come out. So we tried really hard to find all the best data that we could, but it's just, we're limited by what's been reported. So I think those were the main questions about the data shown here. And then, yeah, maybe we'll just go back. Can you go back one slide, Mary Ellen? Sorry. We're going forward. So I wanted to go back to the first slide on screening and testing, which I think is several slides back, and just talk about what the difference between screening and testing is, and then a little bit of information about what we're planning or hoping to plan in the district here.
Right, Andrea, I think this slide right here fits into what you were just talking about, because the question in the chat.
Yeah.
Local data. So I did survey some school nurses across Massachusetts, and this is a sampling of the information that I got from the survey. So I asked what their distance was in the classroom. As you can see, some were 3 feet, some were 3 to 6 feet, some were 6 feet. How many days a week were they in a hybrid or full in school model? And you can see there's a difference there too. Some had K to 3 in for 5 days and 4 to 12 were hybrid, pre-K to 3 for 5 days. Some were all in 4 days a week. What their enrollments were, their positive cases, and then if there was any possible in-school transmission. So with the 3 feet, the 6 feet, 3 to 6 feet, whether they were hybrid or all in, the data was pretty much across the board that some did have some probable in-school transmission and some did not. And the numbers of cases were variable throughout. So there was difference in staff to staff, staff to student, student to staff, student to student, the possible in-school transmission. We do have a few schools that were all in, like pre-K 3 to 5 days, pre-K to 3, 5 days a week, and they had no in-school transmission. We had K to 3 in 5 days a week and 4 to 12 hybrid, and there was no obvious in-school transmission. So these are some things that you can see that it varies across the board. And I think the mitigation strategies that people are using are really an important factor in what the distancing is and the potential for in-school transmission. All right, now we'll go back to your.
Super, thanks. Okay, so quick terminology. I think people use the words testing and screening in a lot of different ways. What we mean is by testing is testing for people who have symptoms. And this is really important, as we've talked about, because obviously if people test positive, we want to rapidly confirm their need to isolate and stay home, rapidly identify their contacts. But I think equally importantly, most people who have symptoms do not have COVID, and the test will be negative. And then we can rapidly permit folks to return to work or to school. And I do think this makes it easier and less daunting, at least personally for me, to report symptoms if I know I can get tested right away. So that's been an area of focus for the district since the beginning of the year. And then very exciting, I think, has been the opportunity in recent months to think about screening, by which we mean testing of people who don't have any symptoms. And I think this provides two real kinds of benefits. The first is that it provides protection. It's just sort of another layer in our mitigation strategies. And the second, I think equally important, is that it provides information. So it gives us really accurate, local, up-to-date information about what's happening in our schools in a way that sort of community rates of positive tests or community rates of new cases doesn't really tell us. So if we go to the next slide, this highlights the sort of the Swiss cheese model of prevention, the idea that we'll have all of these redundant measures in place and try to sort of minimize the probability that any one little virion can make its way through all of these measures to reach the end. And then screening is just another level of protection. So basically the goal is to try to identify people quickly when they have, when they're either asymptomatic or pre-symptomatic, and prevent and catch them and keep them home before they're able to transmit to other people. And I think people have seen a lot of press. It's been really widely implemented in colleges and universities very successfully. And there are actually a lot of private schools in Massachusetts who have implemented this as well. And so there's also some modeling data. I'll show you a little bit later on another slide that implementing screening may actually enable us to have full-time in-person school at the same total infection risk as hybrid learning without screening. And that becomes especially true as community rates rise. So we've been part of a group called the Massachusetts Safer Teachers, Safer Students Collaborative, which has been piloting a number of different ways to implement screening of asymptomatic people in schools. And I think learned a lot through that process and have been happy to be able to set up the screening program that we're going to try to roll out soon. So next slide, please. Mary Ellen, do you want to talk about this slide?
Sure. So this is information that is available on our dashboard every week also, and this is just the number of screenings that we've done in the school. That we have screened 6,235 staff. We've been doing the screenings weekly since November, and we'll continue through till the end of the year. We've had 26 positive results, and 10 of those were asymptomatic. Our screening is not technically just a screening, as Dr. Ciarinello explained, because we do allow our staff who are symptomatic or quarantined to participate in our screening. And that really, we are doing more diagnostic testing there. So that's why there's that high number of symptomatic or quarantined positives that we have, because we do allow our staff, because that is an important factor, is having that ease and a quick turnaround time for testing. Our student screenings that we've done, we did 2 at the high school prior to winter break, 1 prior to winter break, 1 after winter break. And then we have provided the opportunity for screening for some of our students who have been quarantined as in-school close contacts. We've had that opportunity to do that. And from our student screenings at the high school, we did find 1 asymptomatic positive. And they, as with the staff, some of the symptomatic or quarantined students who have tested positive, we were really testing them and not screening them.
Great. And I think actually, I wonder if we could go, should we talk about the rest of the screening program, the pooled testing that's on 47, or should I come back to that, Mary Ellen?
We can go to it, I think.
Okay, I just realized that it sort of fits too here. So this is the proposal, the screening program that we're hoping to implement starting soon, and you've received communication about signing up if you are interested. And so the screening that we've done to date has been individual PCR screening, and what we're moving towards is a model that's called pooled screening. So basically, what we do is actually everybody collects their own. It's an anterior nasal swab. I think that was in the question in the chat as well. So not the sort of way back deep nasal swab, but just right in the front of your nose. And it's actually quite tolerable for kids and adults. And you do that at home. So you can do it sort of in the comfort of your home and help your child with it. And then they bring it to school, and then we send it to the lab. And then the lab takes pools of up to 16 people and puts all of those swabs together in a single tube, and then runs a PCR on that tube. And then if that pool tests positive, they have the individual samples saved, and so they can go back and run individual PCRs on each of the swabs and figure out who was the person who tested positive, or people. So you may see that DESE recently announced a screening program for the state that has a slightly different approach, where people have to come back if they were in a positive pool and be retested. And this approach is, I think, so much easier to implement because you don't have to come back and get a second test if you're in a positive pool. So maybe, I think that was the last one on screening. Maybe we can go back to the distancing slides. Oh my goodness, someone is bringing me dinner, which is like really amazing. Thank you. Thank you. Okay, so we wanted to really dig deep into what are the data on distancing. I think this question of 3 versus 6 feet and what difference does it make is the fundamental one that we've been struggling with in terms of finding the kind of data that we wanted. So what we thought we'd do here is sort of review for you the data that we have and where they come from. So this 6-foot recommendation that everyone has been talking about since the beginning of the pandemic really came from this meta-analysis that's shown here. It was a combination of a number of studies put together with this sort of formal statistical meta-analytic approach that tried to look at the risk of transmitting from one person to another at different distances. And the larger graph is shown here, and the inset is blown up between 1 and 2 meters, so 3 and 6 feet. And basically, there was no real substantial difference. There wasn't really a clear inflection point. Like the risk got a little bit lower with every sort of, meter that you were farther apart, but there wasn't a clear inflection point. And I think the most important thing about those data is that they were done in the absence of masking. So we really didn't have data at the beginning of the pandemic to say how the distance impacted risk in the context of people being masked. And we still don't have any direct head-to-head comparison of 3 versus 6 feet in a school context where people are masked. What we do have is the reports that, that Dr. Medina mentioned, and some additional, quite a large literature from Europe and the UK of schools that have been at 3 feet of distance with very low transmission rates. And then we have some local data. I sort of surveyed some parent friends and this is an unofficial survey, but basically there are a number of districts around where people are in school at less than 6 feet. So most of these are in the 3 to 6 feet. We try to get as close to 6 as we can, but it's often 3 to 6. And then Dr. Medina shared the data from the parochial schools. There are also data from Massachusetts Montessori schools that are at, we don't have outcome data, but they are at less than 6 feet. So maybe we could go to the next slide, please. So we shared these other data about other local districts. And then this is a relatively new study that I thought was really interesting. It is not published. So it's from the chief of infectious disease at the Mayo Clinic. So I'm assuming that he is putting his good name behind this study, but I wish it were published to share for you in a peer-reviewed journal. But what they did here was a laboratory evaluation of respiratory droplets coming from one mannequin and landing on another mannequin with or without masking. And the percentages that are shown in the figure are the percentage of the emitted particles that reach the target mannequin. So this is not infection risk. Like in order for infection to occur, there's another set of things have to happen. That has to be enough quantity of virus to cause an infection, and the person actually has to get infected. So there's another probability there that these would be multiplied by. But what I think is interesting is they show the data for no masks at all. Then the second sort of row is the source mannequin has a mask on. The third one is the target mannequin has a mask on. And the fourth one is both mannequins are masked. And you can see that at 1 foot, 3 foot, or 6 foot distance. And then it's a little bit hard to read the labels, but the sort of tealish color is no mask. The sort of royal blue color is a disposable mask. And then the other bluish color is a fabric mask. So in this study, the two types of masks were really similar. And I think what's particularly interesting is that when both mannequins were masked, distance didn't matter at all. And the risk was less than 0.5% in all cases. So I think, again, this is not, this is a simulation study, but I think it gives us a good sense of how much masking has a much greater impact than distancing. And yeah, that was the type of masking that they had. So maybe we can go to the next slide. So when we think about, what would be the impact on potential COVID risk if we went from a hybrid schedule to a more full-time schedule, and if doing so required people to go from 6 feet to 3 feet. And so the way that this would impact risk potentially is in a couple of different ways. So one is the number of contact hours. So if you have twice as many people in the room and they were there, we're not going to go to 5 days, but if we went, as this example, if somebody went from 2 days to 5 days, it would increase your number of contact hours by a factor of 5, because you'd have twice as many people there and they'd be there for 2.5 times as many days. And then there's this sort of potential risk, like does it increase the risk of droplet transmission as a function of the distance itself? And as we said, we have no real evidence on that with masks, but probably not, but we don't know. And then there's another consideration, which is, and Kailash can speak to this better than I can, but does it potentially increase the risk of aerosol transmission? Because now you have more sort of bodies breathing in a room that is at the same volume and has the same air changes per hour as it had before. So again, we don't have any empiric data on that with masks, but in the next couple of slides, what we tried to do was use a simulation model to see what the potential impact of those risks might be. So this is work done by a colleague of mine at the Harvard Graduate School of Arts and Sciences, who developed an agent-based simulation model of K-12 schools. So basically simulates all the individual people moving around a school. So you have teachers coming in and out of a room and students in their room, and then everybody goes home to their household members. They have a risk of bringing COVID into the school and then a risk of transmitting it in the school. And so what's shown in this set of outcomes is the average number of secondary cases if a single person walks in the door with COVID the average number of additional people that they will pass COVID on to over 30 days. And she modeled this in the absence of any sort of intervention. So in reality, if you saw a number of cases, you'd probably close the classroom or close the school and we wouldn't let it run for 30 days. But this is, the sort of upper bound on that from the model. And so the vertical axis is these number of secondary cases over 30 days. And as you can see, I just put our numbers in context there because I actually think her model is predicting more cases than we have seen so far. So it gives you some sort of a sense of order of magnitude. And so if what she's done is simulate a number of different conditions. So a hybrid model with low risk, and by which she meant really excellent adherence to masking and probably the lowest possible risk of transmitting one to another in a class. And then she looked at hybrid models and 5-day models under conditions of what were called medium and high risk. So to go from the low to the medium risk scenario, for any person who walked in the door, their risk of transmitting to someone else was twice as high. And to go from the low to the high risk was 3 times as high. So when she modeled this change between hybrid and a 2-day model hybrid and a 5-day model, that already takes into account the impact of the increased contact hours. So the 5-fold increase because you have twice as many people for 2.5 times as many days. And then we don't know about this droplet or aerosol risk. So if you imagine that the green arrow would indicate a situation in which you have a doubling of risk, so maybe distance and aerosol have a double of the risk that one person will transmit to another. And so in that case, the green arrow shows what would happen if we moved, say, from a current strategy of hybrid without any weekly screening to the top of the orange bar is a 5-day strategy, so not a 4-day model, at a doubling of the infection transmission risk, but with weekly screening in place. So that gives some context of what that might look like. And then the purple arrow is if there really is no impact of the distance itself and the aerosol itself, then you would go from a hybrid model with low risk to, say, a 5-day model with low risk. And if you also implemented screening, then the overall transmission risk would change very little. So this is, yeah, I think we talked about this slide, so we can skip that one. So that slide has all the caveats of, simulation modeling, but I think gives us some context and a bit of a sense of the order of magnitude of what we might expect. So I think we just have 2 more slides. One is on the new variants and one is on vaccines. There were a number of questions in the chat about the new variants as well. So, these are data that are coming out like literally hour by hour. So I'll try to give you my updated snapshot. So there are 3 types of emerging variants that I think are important for us to know about. The first one is the one that's been seen originally in the UK, which is called B117. And then there's a South Africa variant, which is called B1351, and a Brazilian one called P1. Unfortunately, they've all been seen in the US, not surprising with international travel as it is. We have the most information about transmissibility from the UK variant. And it seems to be more transmissible, about 40 to 80% more. It's not entirely clear if it's more likely to cause severe illness or death. There was a report from the UK just in the last couple of days that suggested that it might be more likely to cause severe illness. And I think the UK Department of Health that follows these has said there is a possibility that that is true, but the data as of yet, are not sufficient to really answer that question. I think an important thing is that the CDC has estimated that this B117 variant may be the predominant variant in the United States by March. And I think if that is true, we will hopefully have data on the impact of that in our schools. I think a lot of the questions that have come up have been, well, we're starting to see these data from US schools, but these were all probably before most of these variants were really prevalent. And what does that mean for going forward? And I think we really don't know, but I think the value of thinking about having our own screening program is that if we start to see an uptick in cases, we will see it, so we will know. And the lab that we're working with can detect this variant. So I think Mr. Martineau will talk a little bit more about sort of plans to review the local data before any decision is made, but I just wanted to highlight that I think we will actually have really good local data on this question. And then what do the new variants mean for the effectiveness of the vaccines? There have been a couple of ways to look at this question. There's actually, yeah, stay on this slide if you don't mind, just a tiny bit longer. There's a couple of studies where they took serum from people who've been vaccinated in the trials or from non-human primates who participated in the vaccine studies. And they found that the neutralizing antibody titers are the same for the UK variant as for the variants we've seen. So that's very encouraging. And then they looked at the South African variant, and they are lower antibody titers with the Moderna and the Pfizer vaccine, but they're all thought to still be above the threshold level that's needed to neutralize the virus. And across all the vaccine studies, including the ones that came out this week in South Africa, it showed slightly lower effectiveness against preventing any illness, but still nearly 100% effective in preventing hospitalization and death. So I think this is something to watch, but so far reassuring in preventing severe outcomes. And then monoclonal antibodies, which are an IV therapy that we use in outpatients to try to prevent hospitalization, may have some lower effectiveness against the South African variant, but this is not a widely used intervention to date. And then the last slide, I think, is on vaccines and when can we go back to normal. So just to quickly highlight, I think educators are hopefully going to start getting vaccinated soon. I think we're waiting to hear from the state as to the exact timing on that. As mentioned, the vaccines are highly effective in preventing illness and severe illness. I think there's been one patient with severe illness in all of the vaccine trials, and that person really had an oxygen saturation of 93% briefly and never was hospitalized. So really met their trial definition of severe, but did very, very well clinically. And so I think another important question is, though, after you've been vaccinated, can you still get asymptomatic infection and can you still pass it on? And this is where we really don't know. There's some data from a couple of the trials that try to answer this question. So there were monkeys in the Moderna and J&J study that did not get sick, and they had no virus in their lungs, but they did have virus in their nose. So maybe they could transmit to other monkeys. We don't know. In the Moderna study, people came at day 1 for their first dose, and then they came at day 28 for their second dose. And when they showed up on their day 28 visit, they did an asymptomatic swab. And so at that visit, so after the first dose, before the second, there was a 67% reduction in the number of people who were asymptomatic but tested positive. So that I think is really encouraging. And then the studies did not they didn't swab people weekly who were asymptomatic after their vaccines. So those studies are ongoing. I think many of us are participating in these studies of sort of weekly PCR screening in healthcare workers who've been vaccinated. So hopefully we'll start to see some data from these large studies about whether we can still acquire asymptomatic infection. I think one reassuring point is that it definitely prevents symptomatic infection. And we know that people without symptoms transmit COVID much less than people with symptoms. And so that's reassuring. And then we have certainly a lot of paradigms from other vaccines that can prevent, even though they don't completely prevent infection, they do an amazing job of preventing transmission at the population level. So I think those things are reassuring. I think whether you are, the current guidance is that even after you've been vaccinated, we should continue masking and distancing and doing all of the mitigation measures that we have. And there's no change recommended to the quarantine or testing guidance for people who've been exposed after vaccination. And hopefully by the time everyone around us is vaccinated, I think we'll have more data on this question about asymptomatic transmission and be able to hopefully start to relax some of these measures. But as of now, I'm sort of a cautious and conservative person. So I think it is fair to say that we don't have the data to know whether vaccines will fully prevent asymptomatic transmission at this point. And then a lot of people have asked, well, when will the kids be vaccinated? So the Pfizer vaccine is approved for 16 and up already, the Moderna for 18 and up. There are trials ongoing in the younger ages and enrolling for 12 to 17-year-olds and planned for 5 to 12-year-olds. I think when healthy children will likely be quite late in the stages of the vaccine rollout as of now. So I think we're sort of still waiting to see when that timing would be, but probably not before the summer, late summer at the very earliest, I think is what we're hearing. I think that's the last slide.
Thank you all. I'll send it right back to you, Greg.
So thank you. That was a wealth of information, and I think it just supports the fact that our medical advisory team and Kailash has been meeting weekly and trying to present us with the most accurate data to make, again, evidence-based decisions. I think one of the challenges is when we're planning forward, we're really thinking about what might be in March. And I can assure you that in a pandemic, what we know in March will be probably different than what we know today. but we do need to plan forward. We need to think about those logistics and the operational aspects. And the medical advisory team will continue to meet weekly and look at the evidence based on the screening and looking at what's happening at the local level and state level, as well as the new variants and the new strains to make decisions for our students and recommendations. So that has been key to our work. And again, has allowed us, I think, to move forward with great information and allow us to make good decisions. So we are going to shift the presentation back to some of the logistics in terms of moving to increased in-person learning. So I think we can't emphasize enough the model of mitigation efforts that we have in our district. So when we talk about increasing in-person learning, the mitigation strategies remain essential in terms of mitigating the spread of the virus. We're very excited about the screening. We think that will give us another layer of data to evaluate on a weekly basis. And again, the masks, the distancing, the ventilation, the hand washing, and so forth are all critical to the work we've been doing. You know, one example is really looking at the masks. So as we increase in-person learning, you know, part of the conversations the medical advisory team has been discussing is, do we need to have a stronger recommendation around the types of masks? Do we need surgical masks? Do we need to double mask? So those are the recommendations that we're looking at, presenting that to the community once some decisions are made. Also, in terms of ventilation, so you know, Kailash has been essential in helping us really thinking about maximizing ventilation and air dilution in our classrooms. As we move to increase in-person learning, we will be installing HEPA filters in all classrooms as another mitigation effort to make sure the air quality is sound in all the classrooms. And Mr. Lavoie will speak to that in a little bit. So the current learning model, so as we had planned to reopen in the summer, we really talked about planning across a continuum from 100% in person to hybrid to full remote. So we've been in the hybrid model with good success across our 10 schools. We've had strategic remote times for certain classrooms when there has been quarantine required. And then we've offered the standalone remote programs for families who felt like that was the safest option for a family. So over the fall, we've collected a lot of data, we've learned a lot, and I think we added COVID-19 screening of educators, which again provided us with another data set to see what was happening within our faculty and staff environment and context. But what we did not have is COVID-19 screening of students. So again, as we move to increase in-person learning, we think having screening and better data is essential to make just-in-time decisions. So just kind of summarizing where we were in the reopening in August and September, the Department of Elementary and Secondary Education provided districts with guidance around social distancing, and physical distancing was an essential component to the mitigation of the transmission of the virus. And as Dr. Ciarnello said, there was no precise physical distancing threshold for safety. And the studies really were 6 feet unmasked from the beginning, and really about the aerosolization. So as a district, we took the most conservative approach of 6 feet as the minimum with masks, with the understanding that we did have the ability to have 3 to 6 feet as a range with masks per Department of Elementary and Secondary guidelines. So what we're looking to do to increase in-person learning is to see what the minimum threshold of physical distancing is within our current context of all of our classrooms to allow for more increased in-person learning. So Mr. Lavoie will speak to that in a little bit, but again, we have tried to take a methodical and a mathematical approach to looking at every learning space that we have so we can give parents real-time data to make informed decisions for their families. And I'll turn it over to Dr. Reinhorn.
Thank you. So now I'm going to talk a little bit about the models that we are working toward. What we're now referring to as the 1+4 in-person model is what we are working toward. It would be 1 day remote on Mondays and 4 days in person, Tuesday through Friday. And this would replace the 2-day-a-week hybrid. The Mondays remote have proven to be very helpful in terms of our first priority, which is health and safety in the screening process and all of the elements that follow the screening. In addition, in terms of building maintenance and all of the processes that are happening with our facilities. So maintaining that Monday remote is an important part of keeping that priority on health and safety. But then moving from 2 days in person to 4 days in person allows us to increase that in-person learning time, which in the survey data from educators, families, and students, we heard consistently from many stakeholders that it is incredibly valuable, and this has been our goal all along. The standalone remote program is an important option for some of our families, and that program will remain in place throughout the year. And in this next phase of the learning, when the time is right, we would be at the point where we would have COVID-19 screening for students and for teachers, which is an important element, and then all of the other mitigation strategies that we have had. One of the pressing questions that Mr. Martineau was just talking about is about the distancing. So I'm going to turn it over to Keith Lavoie, who will tell us a little bit more about the work we're doing for both lunches and classrooms around distancing.
Thank you, Dr. Reinhorn. Just as we started last spring, we really took a lot of time to investigate our classrooms, understand their dimensions, understand the HVAC systems that were involved and how it all worked together. Certainly it was a steep learning curve, and I do want to thank Kailash Viswanathan for all his guidance through it all. He has been an incredible resource for us, and he continues to be as we make these efforts moving forward. But the thing that we added to our repertoire of things that we're really exploring, and like Greg mentioned earlier, is a mathematical approach to understanding how the dimensions impact the capacity and our ability to distance our students and our staff safely. So we did partner with Canon Design, a gentleman by the name of Paul Mills, who has really been on the cutting edge of a lot of these mathematical formulas that allow schools to make decisions around their capacity. He has worked very closely with the University of Texas and a lot of institutions in the area with how they are going to apply metrics to the understanding of their spaces. So what we've done is we have partnered with Canon Design, and Paul has been able to develop a tool for us that allows us to do a couple of different things. The first is, and Greg, do you mind clicking on the second tab? That one there, yep. This tab here really gives us some great evidence about putting some basic information into a calculator. So this allows us to talk about the square footage of a space. It accounts for the personal space of students, the space needed for teachers, and that we're trying to achieve. And we can adjust this matrix up and down, 6 feet down to 3, and we can really see the types of distancing we're able to. Been great about this tool is it allows out of different classrooms and make adjustments as needed. And if we want to bump to the fourth tab there, Greg. And this is where the work really gets detailed. Paul has been able to add the specific detail of each individual classroom in the entire district within this analysis, which has been great to have. So we've been able to bounce between schools and in between classrooms and make adjustments as needed. So this has been something that has been incredibly valuable. And the best part about it is, and we've had it now for a couple of weeks, we've been able to take what this tool has been able to show us and then translate it into how classrooms can be set up. And we have done a few classrooms, a proof of concept, and not all the buildings, but most of the buildings in the district, to see if this calculator is actually proving to be true, and it is. So we have gotten a positive response from the use of it, and the hope in the next couple of weeks is once we finalize the number of students that will be coming into the classrooms, we'll be able to get down to a granular detail of the distancing that we'll be able to maximize. So that's just going to be a great resource for us to have in our planning process. Greg, is there anything more that you'd like me to add about that? Do you want to go into this, or?
No, I would just like to thank Keith and the team for doing some ground proofing to make sure that what the data supports on the tool actually is what we are experiencing in classrooms. So we've been doing some random checks, and the tool has been very accurate to date. So it has given us the ability to look at every classroom and say, with X number of students, this is the maximum social distancing that we can provide. And what we're finding is that it's not a minimum of 3 feet. There is a greater social distancing range than we had anticipated. Keith, I'm not sure if you want to speak to that.
Yes, I will. So through the work that we've been able to do, we have been able to get a vast majority of our classrooms with anticipated capacities to 5 feet of distancing, which has been an excellent thing to kind of see come true through using the tool. There are a few classrooms throughout the district that will be at 4 feet, but nothing less than that. And the hope is that wherever possible, we're going to be able to get to that 6 feet of distance, which we have now, which I think is going to be achieved in a number of classrooms throughout the district. But this is where we are really going to be focusing in the next couple of weeks as the data of our community come in and what people's choices are. We're really going to be able to get down to that granular detail, and then really help the teachers, principals and teachers make decisions about their classroom to make sure that we maximize every square foot that we can. I think the teachers and principals have done an amazing job so far about being creative with their instruction, being creative with their learning spaces. And this is just the next layer of that. But I think a lot of the work that we did in the spring and the summer to prepare is really going to help us with this next phase. And honestly, I look forward to the opportunity of working with the principals to figure out the ways that we're going to be able to make it happen. The other thing I would add, and it was mentioned before, is that in the air quality study that Kailash did for us this summer, if we do return to full in-person learning, his recommendation was to have HEPA filtration in every classroom. And that is something that we are going to have in place prior to the reopening of the K-12, K-5 buildings.
So Keith, I'll just add a couple of comments. First, that in terms of the way the classrooms are set up, where students are facing the same direction, that will still be the case with increased in-person learning. The distance would be reduced, but again, the same strategy that we employed when we reopened in the fall. The second thing is at lunch, we are required to maintain 6 feet of social distancing. So Keith and his team are looking at lunches and making sure that we have structures and space to accommodate 6 feet of unmasked social distancing. So we are able to accommodate that with some creativity. And then a lot of the work that we're doing is we're having to take furniture out of storage. We're actually having to purchase HEPA filters and purchase additional desks to make this a reality for our school districts. So there are a lot of behind the scene purchases that we need to make. And we are using some of the federal grant money that we are receiving to increase in-person learning. So Keith and his team have really worked hard on preparing the work to make this happen in March.
Thank you. And I'll just one last comment about distancing in response to a couple questions in the Q&A about hallways. And we're focusing right now on the elementary schools, and travel through the hallways is very much controlled in the sense that classes are moving when they are with their teachers, and we have been able to maintain distance and would be able to continue with that. And we're again, with snacks, it would be, and any kind of mask breaks would still be mandatory 6 feet of distancing when anytime masks are off. So, so in summary, the health and safety of our students, faculty, and staff remain a priority, and that will continue to be true as we move forward. Increased in-person learning has always been the goal. We really believe in, and I think all of the stakeholders have affirmed the power of that in-person learning. The district, the process that we need to go through in order to be ready for any kind of a transition is complex. And so it needs to begin now. And although it can begin now, we can continue to monitor the data, which we will do. The data, both locally and more broadly that you heard about tonight, supports the fact that mitigation strategies in schools are effective. COVID-19 screening will be offered weekly for students and staff in our district. The medical advisory team, who, as we've said, have been so crucial throughout this process, will continue to meet on a weekly basis and analyze the current conditions and make recommendations. This will set us up so that on Tuesday, March 16th, the medical advisory team will be able to make a recommendation about the transition to a 1+4 model. Assuming if that is their recommendation and we are able to move forward with that, March 22nd would be when the elementary schools would transition to the 1+4 model, and the standalone remote program would continue. A couple of considerations that relate to questions that have been asked. It is the details of class assignments and staffing depend on families' choices. So we aim to minimize disruption to class assignments, and we are committed to keeping the class sizes reasonable, but we're not able to predict exactly what the impacts will be until we have information about what families have selected for models. In Northborough, students who are moving from the SARP model to the 1+4 model will ideally be assigned to their neighborhood school. However, we want to be clear that if that's not possible, we would contact a family before assigning their student to a different school. So in terms of next steps, you already have the form that allows you to sign up for the screening and to select a model. This form is due on Sunday, February 7th at 5 p.m. And we want to be clear that no response, if the form is not completed, we will assume that that means the family's decision is to stay in their current model. So if you're in the current 2-day hybrid, you will be assigned to the 4-day hybrid model. And if you are in the current standalone remote program, you will stay in the standalone remote program.
So we'll just add, Stephanie, the way families can help is sign up for screening. So obviously it's a family decision to participate in the screening, but the more families who participate, the better data we'll have to make informed decisions. Ideally, we would have 80% or greater participation in family of students in each school. And that would give us a really great data set to determine what's happening within the context of our schools. I'll also add that Mary Ellen and her team are also creating a symptomatic testing program. So if your son or daughter or child has symptoms, they should not participate in pool testing. And we would have a testing program that a student could access rather quickly, or a family could access rather quickly. That is a PCR test. And Mary Ellen is working out the details on that program again. trying to get good information as quickly as we can into the hands of families. So in terms of the timeline, so Dr. Reinhorn talked about the deadline for the form, and many families are talking about, it's such a quick decision. I think that we need the information to be able to plan moving forward. But I also will emphasize that no decision is being made now, that the medical advisory team will be meeting weekly to ultimately decide if the conditions will allow us to move to increased in-person learning on March 22nd. With the virus, this could change what we know today, could change what we know next week at this time. There still remains the chance that we could go into a remote model, which I hope not, but again, we don't know, and we're being planful and hopeful that we will be able to move to greater in-person learning. And by March 5th, so Mary Ellen and her team are working on having the screening fully implemented pre-K through 12. And then hopefully, if all things go well and the trajectory of the virus is such that we're seeing, we're learning more and we're able, we will begin the 1+4 model. And again, we shared a timeline with families, and right now, as you can see, Tuesday, February 2nd, we are at the webinar, so we're holding fast to the timeline that we presented. So again, I also would like to thank families for submitting questions, and we encourage, if there are questions, to submit those in the Q&A. Most likely we will not get to all of the questions that are being asked, but we will endeavor to create an FAQ and share that out with the community with answers to the questions. So the first question, really, I think we've addressed, with the new strains of COVID, with the new strains of COVID, they are seeing increasing numbers in children as well, and school testing is showing more COVID in children as I read. Is this being taken into account? And again, that is where we're meeting with the medical advisory team weekly. And Dr. Cianella presented, what we know now about the new strains, and new information will allow us to make good decisions at the time. So the next question is, what is the threshold for in-school transmission? Currently, there hasn't been any threshold, which to me is a safe level. When there is in-school transmission, will there be an investigation into the reason and corrective action if possible? So maybe a person from the medical advisory team would like to answer this question.
I can start and then someone else can tag in. I know we all want that hard and fast number, but what's the number where we'll go remote? At the beginning of the year, we thought we had numbers, then we don't have numbers, because what we're really looking at, and the reason we would need to go remote in our schools, is because of in-school transmission or because of not enough staff to teach the students that are in school. When there is in-school transmission, the medical, or a potential for in-school transmission or a probable in-school transmission, the medical advisory team is the first people we call to talk about. And it's been on a Saturday morning, a Sunday evening. They really have been invaluable to us as a resource for when we do suspect the potential for in-school transmission, and we talk about all of the things that we need to do and where the breakdown may have happened, or where the in-school transmission may have happened, and how can we support those schools to not, so it won't happen again. And what do we need to do? Does it need to be more education? Do we need to have more hand washing lessons? Do we need to have more hand sanitizer? Does it need to be more cleaning? So wherever the breakdown may have happened, or wherever we see it, the education, there's always that chance for education again, and to find out, and so it won't happen again. Anybody else want to add on to that?
Well said.
And I just want to thank, one of the reasons we're able to quickly detect in-school transmission is because of all the hard work of Mary Ellen Emily and Kristen and all the school nurses who at any hour of the day will start their contact tracing to make sure there is no in-school transmission and act on it when it is.
Thank you, Safdar. So the next question is, why is the 4 days being considered when teachers have not even been vaccinated yet? So part of the timing of increasing in-person learning is to align it with the rollout of educator vaccination. However, it's not conditional on returning to 4 days in person, having teachers vaccinated. We are trying to stay in tune to the vaccination rollout. Mary Ellen and our boards of health have been outstanding in keeping us updated. And Mary Ellen, I'm not sure if you want to speak briefly about what our plans are for vaccinating teachers.
Sure. K through 12 staff are in phase 2C. Phase 2 just started yesterday, and that would be the 75 and over. And then once they're all vaccinated, it goes down to 2B is 65 and people with 2 comorbidities. And then 2C is the K to 12 staff. We have, most people have signed up for notifications through the towns for when vaccine becomes available and it's in their phase. And there's a automatic notification that will be sent out as to where the vaccine is available and when they can get it. The town of Northborough is setting up a vaccine site, and they have opened it up, and they got their first 100 signups in the first 5 minutes they opened, I think. But that's going to be eventually, hopefully that will build, and that will be a place where we could get our staff vaccinated too. So the plans are in motion for all of that when 2C becomes available.
So the next question, we received several questions around the class sizes, specifically around the standalone remote program, and what would happen if more families select the standalone remote program to the current remote program class sizes. Stephanie, do you want to answer that question?
Sure. So the first thing I want to say is that we used the survey data from the survey that was in sort of November going into December, and carefully analyzed, disaggregating grade by grade to be able to predict and project what the movement might look like from SARP to hybrid and from hybrid to SARP, to make sure that this was within the realm of possibility. We have already started working on hiring and on looking at where there are educators in the system who might be, for example, working with students on remote hybrid days, and those people would then be reassigned to do other work because there would no longer be remote hybrid days on Tuesday through Friday. So we're looking at all of the staffing possibilities, and as soon as we know the exact numbers, we will be able to look at the exact implications. But our goal is, to keep those class sizes as close to either where they are or that 25 as possible.
So this next question is around masking and double masking, and what will be the district's recommendation. So again, I know Dr. Cianello presented some information, and Dr. Carey, around masking. So we will be making, we will be revisiting masking and making a more formal recommendation around when we increase in-person learning. Are we requiring surgical masks? Are we requiring double masking? What will the changes be? So we will be communicating that in the next several weeks.
I think it's important to know that one of the key factors in the mitigation strategy of wearing a mask is the fit of the mask, and to have a really well-fitted mask, as you saw in the slide that Dr. Cianello showed. When a surgical mask had a lot of different percentages that it was protecting. It depended on the fit of the mask, the level of protection.
And I'll just add that our students have been outstanding. They have done an excellent job wearing their masks. We have had no disciplinary issues as a result of students unwilling to wear masks. parents have been outstanding in terms of sending students with masks and following the protocol. So we've had great fidelity and really no concerns with mask wearing in our organization at this point in time. The other question too that was asked that is not on here is, will families know what the social distancing minimum would be in their classroom prior to making a decision on February 7th? So what we will not know is the maximum space provided, but we can provide some estimates in terms of, we know that there are 20 students in a particular class, as we would have hoped to launch the school year without a pandemic. What would the social distancing be with full capacity? And Mr. Lavoie has been working on that. So Keith, do you want to comment on that question?
Yeah, sure. That is where we wanted to make sure we had as much clarity as possible. Like Greg said, if we did not have the pandemic and this was a normal school year, the classroom sizes would range between 16 and low 20s. Typically around 20 would be our maximum number. So we really looked at that when we were devising the tool. And what we were able to find is that in a vast majority of our classrooms with 20 students in it, we're able to get a 5-foot distance of social distancing inputted. So that was the vast majority of classrooms were at that mark for 20 students in the class.
Thank you. So the next question is something we all think about, which is, our students have adapted to this hybrid model, 2 days on, 2 days off, over the past many months. Many parents have reported that students are finally in routines, families are finally in routines, and we're going to disrupt the routines that we've established. So we have given this a lot of thought. We definitely appreciate all the accommodations families have made to make this work and sacrifices they've made to make this work. We believe that in-person learning, there's no second best. That although the hybrid model that we've used has been working okay, we think 4 days of in-person learning is far better, and it's worth the potential disruption to us as an organization, to teachers, to rethinking about schedules, to busing, to lunches, because if you think about it, if we calculate the number of days students will be increased in-person learning, if we're able to do this safely, we're talking potentially greater than 20 to 25 days additional in-person learning days that they would have rather than if we just stayed in the hybrid model that we currently exist. And if you multiply those days by the number of hours, it's a significant amount of learning of in-person learning that students will gain. And I'll just comment too, so what is lost in this remote hybrid are the peer-to-peer learning that happens, the socialization, and then also Dr. Medina talked about the social and emotional well-being of our students that although they might not always seem to love school, students have really anecdotally commented to us that they prefer being in person with their friends, with their teachers, than these remote hybrid models. So we've done the advantages and disadvantages, and we feel that it is worth the effort and the potential disruption. But again, we'll endeavor to try to minimize disruptions to class placements, schedules, and families as best we can. So the next question is, will high school schedule and teachers change? So we are doing this in a phased approach. So we are starting to look at K through 5 as our initial work. Our Childre Middle School, Melican, and Algonquin Regional High School are starting to have conversations about the potential of increasing in-person learning. And we will begin those conversations in earnest after February break. I will just share that it is far more complex at the middle and high school levels in terms of student schedules and the sheer number of students. But again, that work will begin after February break. So the next question, if our student chooses full remote for the sake of safety, does this mean she has to blow up her schedule and all the relationships she's built with her teachers over the last 4 months? Stephanie, do you want to take this one?
Sure. I think the way this is written, this is really probably from a secondary family, which again, we're really focused, our descriptions and responses tonight have been focused on the K-5. But again, we're at the elementary level. Certain transitions could mean a change of teachers, which means new relationships and means transition. However, that has been happening already with students moving between the models, and the teachers have had a tremendous amount of communication across schools at times and across the models. They plan together on the SARP side and the hybrid side, so they are connected in terms of their curriculum and are working really hard to smooth out these transitions when they happen. So we do it every year when kids move into town and move out of town, but we've been doing it a lot more this year, and teachers have done a phenomenal job with the transitions.
Yeah, so I think I think our greatest asset are our educators, and they're very skilled at creating classroom communities and welcoming new students to those communities, and they're very thoughtful and thorough in the way they go about making that happen. So as students, if a hybrid student transitions to a standalone remote program, the teacher will spend the time necessary to continue to build the classroom dynamic in the classroom community and support all learners in that environment. So the next question is, how will lunch and recess be handled and snack? So Keith, do you want to talk about this a little bit? Mary Ellen?
Sure, Mary Ellen and I can tag team it. You're going to see some creativity when it comes to lunches. We are maintaining the 6 feet of distance when students are having their lunch, and we've had to be creative with some of the schools. Once again, it does come down to the number of children that are going to be back in the buildings and then the capacity of those spaces accordingly. But I've been in contact with all the principals. We have a plan and a backup plan, and also thinking of creative ways to make it happen. So that will be something that'll be rolled out at the individual schools, but we will be maintaining 6 feet of distance for all lunch waves. Mary Ellen, do you want to comment about recess and snacks?
Sure. Just to let you know, whenever masks aren't on for mask breaks or lunch, 6 feet is it. It's a non-negotiable. It has to be a minimum of 6 feet. So that is something that's non-negotiable through all of this. Recess, I believe recess will be as it's been. It's not a mask break at recess, and the classrooms remain, they do not intermingle. They have their own recess supplies. And snack is something that's going to be worked out individually at each school, how it will work to maintain that distance. Will the students go to the cafeteria to have their snack? Will they take turns at different times? Will they be able to go outside? That's another option that we've been put into the mix, is, tents and eating outside, eating outdoors if necessary, because we're looking at springtime, hopefully. Today, we don't know that, but pretty soon it'll be right around the corner. And so that's always an option. So this is a lot of things. Like we said, the planning has begun, and the planning continues as we go through this, and we'll have guidelines for each school about these processes.
All right, with that said, I'm just going to quickly scroll back to our opening slide. So first of all, I want to thank parents for the partnership over the course of this year. I think a partnership in a normal year is essential, and this year it has been ever more important in navigating these very challenging times for families. and as us as an organizational system. I think we are asking families to seriously consider what is the best option for the family. If you have questions that you would like to ask, you can send those questions to me and I will make sure they're answered. If we were not able to get to a question that was asked in the Q&A, we will be creating an FAQ and be sending that out before the end of the week. We also will be sharing this webinar again, this recording, so that will be a resource to families. And I think the key takeaway I think I would like to leave parents with is that we are planning forward. We do not know what March will bring in terms of the virus trajectory. We will continue to use the expertise of our medical advisory team to make evidence-based decisions on a weekly basis. We'll continue to review cases that appear, and I think that it has proven as an effective strategy for our district. And ultimately, I think the health and safety and well-being of our students and faculty and staff has been the top priority, and that will remain a priority for us. So I'd like to end by again thanking our medical advisory team. They have been so gracious in their volunteering, and Mary Ellen, as she indicated, we've had many Saturday and Sunday meetings. They are on call to Mary Ellen, and I know we are very grateful. Ways, you know, so we are the envy of many districts who do not have this level of expertise and resource. I also would like to personally thank Dr. Medina. He has been outstanding. He has really helped us with this testing and being the ordering physician, which has been tremendous and has been a great resource to the district. So thank you, Dr. Medina. And Kailash has been a great resource in terms of helping us think about the air quality for students. So we are very fortunate. We are thankful for what we have and look forward to the future. And again, if you have questions, please submit those to me. And more information will follow in the days and weeks ahead as we move forward with this planning process. So thank you and have a great evening.